Warm welcome to participants in the meeting for the WHO European region on achieving the elimination of viral hepatitis within evolving health systems. As you know, you have interpretation. If you need, you can click on the interpretation button. The World Hepatitis Alliance this week was a major opportunity to discuss and advance the viral hepatitis agenda globally to drive progress towards elimination as a public health threat by 2030. Today, as part of the World Hepatitis Summit, we have a special meeting to focus on progress and issues to be addressed in our region. Viral hepatitis is a major public health challenge with important disease burden in our region. Estimates indicates 14 million people with chronic hepatitis B and 12 million with chronic hepatitis C infection, resulting in more than 100,000 people dying from viral hepatitis-related death in the region every year. Although the region has not achieved the testing and treatment coverage targets set for 2020, many countries in our region now have developed national plans for viral hepatitis. And recently, high-burden countries in Central Asia, namely Kyrgyzstan, Uzbekistan, and Kazakhstan, have committed state funding for their national plan, including for hepatitis treatment. This is a very significant step towards elimination in our region. We now have the possibility to use the DAA at affordable price in low and middle income countries. Further simplification and decentralization of testing and treatment and continuous advocacy and community participation will allow the necessary rapid increase in access to testing and treatment to reach our targets. Many good practices in various areas of the health sector response to viral hepatitis have been implemented through member states in the WHO European region and should be shared across countries. As you know, WHO is in the process of finalizing the action plans for ending AIDS and eliminating viral hepatitis and STI epidemics in the region for 2020-2030. With specific actions from member states, WHO and partners for ensuring a strategic shift to reach elimination. The plans should be endorsed at the 72nd World WHO Regional Committee meeting in September this year and will guide us for the next 8 years. Today's regional meetings aims at reviewing countries' progress, challenges, exchange good practices in the health sector response to viral hepatitis, and discuss political engagement and key actions required to operationalize the incoming regional action plans. I wish you all a fruitful session. Thank you. And I will now leave the floor to Kerry Jem for the World Hepatitis Alliance for his welcoming remarks. Over to you, Kerry.
Thanks so much, Nicole. And thank you everyone for attending this workshop. I'm just going to say a few words so we can get to the great program that we have. But I mean, World Hepatitis Alliance, it's always great to be here with our friends in Europe. I mean, Europe is one of our biggest constituencies. We have 71 members in the European region. And in so many ways, the organization, civil society, and the community in Europe is leading the way in hepatitis elimination through the use of peers, through the decentralization of services, through providing really great services to the people who need it most. So that's why it's always a pleasure to be at these meetings and hear all the great work that's being done. And we're really proud at the World Hepatitis Alliance for our partnership with WHO, Euro, with partnership with all of you. And we're really pleased to welcome you to the World Hepatitis Summit today. So thank you very much.
Thanks, Carrie. So I will now share my screen and we'll move to the agenda of the meeting.
Την κατασκευή του περιπτέρου.
So if you can see the screen, we will have a session until 11:30 this morning. And we will start by I will present the key features of the hepatitis section of the Regional Action Plan, and then we will move to a session presenting abstracts that were not in the main sessions of the World Hepatitis Summit this week, but they are very interesting and important for our region, one from Ireland and one from Greece. And then we will follow by presentation from national programs about good practices and key actions towards elimination that are very important to share with other countries and colleagues and partners. One from Spain, from Uzbekistan, and then the last one from Georgia. Of course, the two sessions will have a question and answer part. So feel free to put your questions and comments in the chat, and then we will give you the floor. So I will start by presenting the draft action plan for ending AIDS and eliminating viral hepatitis and STI epidemics in the region for 2022-2030. But of course, I will focus on the hepatitis section. So you can see that for the first time, the same as for the global strategy, we have 3 plans in one document just to show and focus on the interaction across the HIV, viral hepatitis, and STI issues, and with the first strategic direction in the regional plan for creating a unified vision for ending these epidemics within a health system approach focused on universal health coverage and decentralization up to primary health care. The process, first, this plan is really in line with the global health sector strategy that was endorsed very recently. So we are very much aligned. We had several consultations, including an expert consultation in November, and then a very large consultation in February with member states and partners and community with online feedback. So now we're at the stage of the final draft that is going to be presented and has been presented actually yesterday at the standing committee for the regional committee. And the last step will be the endorsement, and including the endorsement of a resolution for the region in September this year. So the situation, I already given some data, but we have 90,000 estimated incident cases of hepatitis B and 300,000 incident cases of hepatitis C in 2020. We have significant mortality, more than 100,000 people dying every year of hepatitis. Not all countries have plans, 33 countries have. Major progress in hepatitis B control through immunization have been achieved, but where we are lagging behind is testing and treatment coverage with very slow progress. Hepatitis B, 19% diagnosed and 2% treated, and hepatitis C, 24% diagnosed and 8% treated. This may be a small underestimate because we are not monitoring what happens in the private sector. Hepatitis surveillance and monitoring still requires significant development. So the plan has targets. The impact targets are giving absolute numbers now. And so for monitoring the impact of the immunization program, you're familiar with the impact targets of 0.1% of HBs antigen prevalence in vaccinated cohort for 2030. You can see that we have targets for 2030, and then very importantly, interim targets for 2025 to see where we are towards elimination. In terms of the new infection for Hep B and Hep C, you can see the very ambitious absolute numbers, 2 per 100,000 for Hep B and 5 per 100,000 for Hep C in 2030. We also have specific targets for new Hep C infection among people who inject drugs. and mortality targets of 4 per 100,000 for Hep B and 2 per 100,000 for Hep C by 2030. Here are the coverage targets for testing and treatment for Hep B and C. We aim for 60% testing and 50% treatment coverage by 2025 and 90% testing and 80% treatment coverage by 2030 for hepatitis C. For the vaccination third dose coverage, we're already doing very good. We aim for 95% coverage by 2030. We also recommend to test and screen pregnant women for hepatitis B, and we aim for 95% coverage by 2030. And we also have very ambitious targets for timely birth dose and other intervention to prevent mother-to-child transmission of HBV. But we are at the baseline in 2020, we're already doing quite well. Very important, we need to ensure 100% of blood units screen and very good coverage, 100% of safe injection in healthcare setting, which is still a major issue in certain parts of our region. We included in our action plan targets on sterile injection equipment for people who inject drug. We know that we have problem for measuring this indicator, and there may be some changes in the measurement of this indicator, but we kept it in the regional plan as an important indicator to measure. And we have a final coverage indicator that is not in the global strategy, but is very important for our region, is the coverage of OST for people who inject drugs to reach 40% by 2025 already. And those targets now are what we call supportive environment targets. It's about having 100% of countries with costed plan to eliminate hepatitis B and C with measurable targets and indicator. To have also very good burden of disease estimates and annual or every 2 years reporting on the cascades. So major efforts to improve surveillance and monitoring of progress. And finally, an indicator on integration with HIV, which is the proportion of people living with HIV testing and cured from hepatitis C. So those are the very ambitious targets that we need to achieve in order to reach elimination. So these slides are a bit busy, but I will drive you through it and simplify the message. So those are the priority actions for countries on the left and for WHO and partners on the right, across all the priority areas. So for strategic information, we need to improve burden of disease estimations through population-based survey and also better understand burden of disease, proportion of deaths and liver cancer attributable to hepatitis B and C. We also need to improve patient registry to understand and monitor the cascade of care, and WHO and partners will provide support for this. WHO will also conduct program reviews and support the validation of hepatitis elimination, including for EMTCT of HBV in countries that have achieved the targets. In the area of prevention, countries have to have a package of intervention for prevention that include vaccination, blood product screening, infection prevention and control, elimination mother-to-child transmission, and harm reduction. Importantly, the prevention of mother-to-child transmission goes through screening of pregnant women, treatment if indicated, burst dose vaccination, and immunoglobulin for infants. In terms of partners, we commit to support these interventions for updated guidelines on prevention, and also implementing WHO injection safety policy and global campaign to strengthen infection prevention and control in the region. In the area of testing, the member states should deliver and scale up the full complement of WHO recommended testing options for hepatitis B and C. And what is about a bit newer is the point of care testing and the self-testing for hepatitis C and incoming self-sampling. So WHO and partners will provide support in this area of work to improve diagnostic technologies and testing approaches and quality assurance processes in countries. Now, in the area of treatment, member states will have to significantly scale up treatment and ensure the most effective treatment regimen are offered, expand the delivery of decentralized, novel primary health care, and sometimes community-based approaches for service delivery of differentiated care. And partners and WHO will support capacity building of decentralized care, so capacity building of non-specialists. We also will develop online regional training curriculum for viral hepatitis management. And we will support countries in diagnosing and managing co-infection and comorbidities. As you know, we have major issue with TB co-infection and MDR-TB, drug use, addiction, and mental health issues in our region. And we also commit to support regional operational research initiative aimed at improving treatment success for drug-resistant TB and co-infection with hepatitis C. This is already ongoing, and we will support countries scale up this research initiative. And will support the improvement of point of care, rapid diagnostic tests for HCV, and other new developments in the area of long-acting pangenotypic direct-acting antivirals and evolution in hepatitis D treatment. We recognize the issue of hepatitis D in the region and will make efforts to address it. Finally, in terms of financing, the countries have to fully fund national hepatitis program, which includes also harm reduction activities and needle and syringe exchange program. And WHO will support and has already supported the development of investment cases for hepatitis program to help countries decide for state funding for treatment, and will provide technical support to countries to develop national plans, forecast the demands for essential medicine and diagnostic, and implement the plan in a manner that meets the need of key population and most at-risk population. So just to reiterate that very soon the plan hopefully will be endorsed with a resolution towards elimination of hepatitis as a public health threat by 2030. Thank you very much for your attention. I will stop sharing my screen and we'll leave the floor to our colleagues for chairing the next session. Thank you.
Excellent. Thank you so much, Nicole. So we'll move to our first abstract session. So again, my name is Kerry James from World Hepatitis Alliance, and my co-chair is Marcelo Naveira from WHO Europe office. We've got two great presentations for you, and then we're going to have some time for questions and answers and discussion at the end. So let's just go right to straight to the first presentation, which is entitled "The Reality of HCV Care in Ireland in 2021. Understanding Complex Barriers to Elimination." And the authors are Nicola Perry and Marcus Keane from the Hepatitis C Partnership in Ireland. So let's play their presentation, please.
Hello. My name is Nicola Perry. I am the Secretary with the Hepatitis C Partnership, which is based in Ireland. I would like to take this opportunity to thank the organisers for the chance for us to speak about this today, which is our presentation around the reality of HCV care in Ireland in 2021, understanding complex barriers to elimination. My co-presenter today will be Marcus Keane, who will be joining us later. So, as I said, I'm with the Hepatitis C Partnership, which is a registered charity in Ireland. It was founded in 2015 and launched on World Hepatitis Day. It's a blend of people who are working in the area, have lived experience, are from the statutory sectors and from the community and voluntary sectors too. And we really had a simple vision back in the day. It was to bring together those interested parties to ensure that nobody should have to die from hepatitis C. Our work since then has focused very much around the following sort of headline topics, which I'll just touch on very briefly. The educational workshops, which take place both in residential settings for IVDUs, or former IVDUs, prison settings, community settings, family support networks, and we would also provide education for those living with hepatitis C and those working with people with hepatitis. We've also done some quite pioneering peer training work along with other stakeholders in terms of clinicians, clinical providers, and we've had some great success. That's one of our actual peer workers there in that photo, who in fact right now as we speak has moved on into full-time employment, partially or rather in part due to doing the peer training. We also do patient support and advocacy that can be direct or more generalized. Health promotion and harm reduction information, we would link in with service provider organisations, service user voices within Ireland, and I suppose do our best to make sure that accurate, up-to-date information about testing, treatment, harm reduction messaging generally is accessible. We also, which would be part of what I'm talking about today in our work with a report we have recently completed, the Roadmap to Zero, we would work quite a lot around advocacy, elimination, and trying to improve service provision via lobbying and policy. So, as I mentioned, the Roadmap to Zero. Why? Why did we do it? The landscape in Ireland, as I think probably with a lot of countries in Western Europe at the time, we're talking about 2020 here, was we were experiencing definitely a bit of disease fatigue. We were all experiencing setbacks and stressors due to the pandemic. And again, which would have been quite current across, similar populations across Western Europe at the time, we had cleared the disease in a lot of people who were available or had been waiting for newer treatments after the advent of the DAAs. And we also, we don't feel that we were pushing very well in terms of getting the messaging out around testing and availability of treatment to people who weren't there ready and waiting at that time. Of course, screening was impacted by COVID and some other factors, and possibly one of our biggest problems that we were experiencing was a divide between what was accessible in urban centres, mainly Dublin, the capital of Ireland, but also even the second and third cities of Ireland. There were still difficult and challenging pathways for people to navigate the cascade of care. So what we wanted to do by providing this report was to look at the infrastructure, measurement, and the stakeholders involved. And most importantly, obviously, to speak to people who were living with Hep C about either they have had treatment, what that was like, and how easy it had been to navigate, or also people around, if they're working in the sector, what was their day-to-day work like? How easy was it for them to support people in either testing or treatment, or indeed aftercare? We had clear strategic priorities. We wanted to, very simply, identify barriers to care, highlight effective models of care where we saw them and identified some key stakeholders and development opportunities, and to, again, most importantly, highlight actual patient service user experiences. The process that we used to go about this, it took place essentially, the launch was right at the end of 2020, and we've been working on this process, obviously in some part hampered by COVID, but also it was a very, very intense, detailed and in-depth process. So we worked pretty much across 2021 within this. Where we stand now at the time of this presentation is we hopefully will have just launched publicly on the 1st of June 2022. So we had our preparatory phase, we had our consultation phase, the drafting of the report itself, and then of course where we are now in real time is the dissemination. And what we're looking at, that is a formal launch, but we're to hopefully engage with the media around that to get some, suppose, interest in it, and to keep it on the agenda so that policymakers do take notice of what our findings were, and also to seek out the key audiences where they are, particularly in terms of policy in this case. So I'm going to hand you over now to my colleague Marcus, who's going to talk about our findings and the recommendations from that. Thank you.
Okay, so I'm going to speak briefly about our findings and our recommendations. So we summarized our findings across 5 key themes. First was reaching and informing people. So when we spoke with health and social care professionals across Ireland, the biggest concern they had in relation to hepatitis C elimination was whether or not we'd be able to reach and inform all of those people who are living in at-risk cohorts and might be living with hepatitis C in the community, and be able to link them effectively to care. The second theme that came out was the accessibility of testing and treatment. So accessibility is largely a function of geography. If you're living in Dublin, a capital city, there's an awful lot of strong public transport links. We've got peer-led services in the community. We've got nurses that can do all the blood work that needs to be done in the community. If you're there, then things work quite well. So there are models that work quite well, but that isn't the same everywhere. If you're outside the capital, if you're in more rural areas, if you're away from major cities, then accessibility of testing and treatment just isn't the same, both in terms of the types of services that are available. So in some places, testing is limited unless you have prior sign-off from a consultant, which is obviously a barrier. And also then just in terms of simple geography. So if you are 50 miles away from the nearest hospital and treatment is hospital-based, that's a barrier that doesn't exist if you're just a mile down the road from a hospital. The third theme that emerged was capacity. So when we spoke with people, we found that even with the best will in the world, if we were relying on hospital services or relying on the GP, the general practitioner network within Ireland to be able to roll out an elimination program, we would struggle. And the reason for that is these services are already stretched, and they are even more so stretched now in relation to COVID. So there are real challenges in that. So whatever solution needs to be adopted in order to drive hepatitis C, it is likely not one that is centered on direct provision by hospitals or even by GPs in the community. The fourth theme that emerged was the issue of maintaining engagement. So it is important that whatever system is there needs to be able to engage people in their care. So health professionals in Dublin, 70% of them felt that everybody with a positive diagnosis didn't go on to engage fully with their treatment program, and that figure rose to 95% when you went outside Dublin, probably to do with some of those accessibility barriers that we spoke about. And finally, the fifth theme that emerged was the fact that there's a lot already there. So we don't need to reinvent the wheel here. what we're doing is building on progress. So hepatitis C is already something that has a policy focus in Ireland. It is already something that has a lot of extremely good and extremely committed people working towards. We have excellent peers, nurses, doctors, consultants working in Ireland on these issues. So it's not a matter of starting from scratch. There's a lot that is already there to build on. So in terms of recommendations, we made 7 recommendations across 3 stages, and these stages are largely sequential. So the first one is understanding the challenge region by region. The second was building pathways to support elimination in a sustainable way. And the third then is then and only then focusing on the actual driving of hepatitis C elimination. So in relation to stage 1, so we feel there's a real need to understand the elimination challenges region by region. So to be able to establish those regional needs with regional experts, because while there are common challenges in addressing hepatitis C, the actual burden of disease may not be the same from place to place. So in some places, it may be heavily related to injecting drug use. In other places, it might be to do with people who have come from regions with high hepatitis C prevalence. So the challenges of reaching those different populations are likely to be different from region to region. So we think that we need to get down there on a granular level, really understand these regional needs with regional experts, set micro-elimination targets, get the resources in place to drive elimination. Recommendation 2 then is taking that knowledge and setting these national and regional elimination plans, and again, or implementation plans. And again, there's a lot of work that is there already that we can build on. Stage 2 is then building the network. So building these pathways that can support elimination in a sustainable way. Recommendation 3 is unblocking existing policy barriers, setting policy to enable elimination. So when we look at policy in Ireland, there are still gaps and blocks there. So for example, treatment in the community is still to a certain extent restricted to people who are receiving opioid substitution treatment. There are policy barriers around, for example, the distribution of hepatitis C drugs. So in some instances, they are reserved mainly to hospital pharmacies and aren't dispersed through community pharmacies. Then in terms of recommendation 4, it's about building that network. And we think that that should be a community-based nurse and peer-led system to drive elimination. So nurses and peers, they are the people who can do a bulk of the work here and who can keep people engaged with the system in the community, really link in with people, really support people to drive towards elimination. And then obviously using a hub and spoke model, so you have engagement with doctors, you have engagement with hospital consultants for that level of expert input when it's needed. Then 5, it's about ensuring utility beyond hepatitis C. So for any system like this, to be attractive to policymakers, it needs to have utility. And we know in Ireland that hepatitis C is one issue in liver care. It's not the only issue in liver care. So this network will be suitable for addressing liver care more broadly in Ireland into the future. Finally, and only when we have that system set up, that's when we need to drive towards hepatitis C elimination. So that's when we need to find these missing thousands. We need to identify the people who are there living in the community who might be at risk of having hepatitis C, and support them to access the system that's there. So access the testing, access treatment, and make that really easy for them to do that. And then finally, recommendation 7 is on focusing on supporting good longer term outcomes. So that's about recognizing that hepatitis C, and in fact many diseases, they don't exist in isolation, but there are other issues, social disadvantage, housing, addiction that can impact on people, and many people living with hepatitis may have these other issues in their lives. So whatever system is there, it should be a touch point for enabling people to access interventions around these other issues as well. Thank you.
Excellent. Thank you so much. And there's so many themes in that presentation that really that we've been discussing a lot here during the summit, bringing services closer to communities, focusing on the needs of our communities beyond just, hepatitis as a singular health concern. So that was terrific. Thank you. So our next presentation is from Giannis Padalidis from the Hellenic Liver Patients Association Prometheus in Greece. And it's called Access for All, a Holistic Intervention for HCV Microelimination Among People in Greek Prisons.
Hello, everyone from Athens, Greece. My name is Yannis Petalidis, and I'm the Fundraising and Resource Mobilization Manager at the Hellenic Liver Patients Association Prometheus. I'm going to present to you the program Access for All, which is a holistic intervention for hepatitis C microelimination among people in Greek prisons. Just a few words about Prometheus. Prometheus is the only Greek civil society organization dedicated to liver patients, and our main mission is to improve access to healthcare and treatment, and to advocate for the rights of every liver patient with added commitment to vulnerable and marginalized populations, such as people who inject drugs, people in prisons, people living in a state of homelessness, migrants, refugees, sex workers. And our vision is to become the bridge which connects marginalized populations with the healthcare system. That's why our mantra is bridging the gap. We believe that these populations are in need of their voice to be heard by the state authorities and the healthcare system officials. A little background about the program. As I said, people in prisons is a group at the forefront of our actions, since they could be characterized as the most marginalized and suppressed, among others. Moreover, there is a huge number among them who are using or have used in the past drugs. And as we know, the prevalence of hepatitis C among people who inject drugs is almost 70%. And this number is also according to the Greek Documentation and Monitoring Center for Drugs. In 2018, we started implementing interventions for HCV elimination in prison settings. And this is why we got informed that there are certain barriers concerning access of people in prisons to healthcare. These barriers, you may see them here. It is limited or inexistent access to screening and diagnostics, poor linkage to a physician and treatment, limited or inexistent medication delivery inside prison settings, and limited follow-up procedures. As I said, we named the program Access for All to stress the importance of the no one left behind strategy concerning the hepatitis C elimination efforts. The program's objectives are to provide all necessary screening and diagnostics in order to link these people to healthcare and deliver medication inside prisons. Of course, we wanted to map the real world challenges and barriers. And since the pandemic started last 2 years, we wanted to revitalize and restore hepatitis C interventions which have been affected by the pandemic, since our healthcare system became dedicated to this. A few words about the methods and the implementation steps. Our first job is to communicate with the prisons director in order to take the necessary okay from him that we are able to implement the program. We visit the prison, we implement the screening process, we check for social security number availability, and when the screening procedure ends, all the anti-HCV plus samples are delivered to the local hospital for HCV RNA examinations, and of course we cooperate closely with the local hepatology clinic for these examinations. And our next job is to record each patient to the national HCV registry and get the state approval, the final state approval to initiate treatment. Following to this, we transfer the prescriptions from the hospital to the local pharmacy, and we deliver the medication inside prison settings. And last but not least, we do the follow-up to ensure that treatment was received by each prisoner. Of course, real world means real challenges and barriers. Our team in the field encountered challenges which at first limited the program's effectiveness. And this was a lesson that became very useful during the rest of the implementation. Let's see a little bit about this. At some prisons, many inmates were refusing to participate at the screening procedure. The reason is that they had seen stigma and discrimination behaviors towards other fellow inmates with communicable diseases. So they did not want to take the risk of getting tested positive and face the same behaviors. In addition, there are certain internal regulations that prohibit working in several posts, such as kitchen or canteen, if someone is diagnosed with HCV, HBV, or HIV. So this fact was another key factor for them to not take the risk of getting diagnosed. The aforementioned facts had a negative impact at the screening process, but the last one, the lack of social security number, especially for undocumented migrants, was a barrier that was a huge barrier that made the program's final stages impossible to implement for those who did not have a social security number. So the next step was to face these challenges and overcome some of the barriers. These challenges made us change our strategies and approaches, try new methods, and in order to overcome the barriers and increase our impact and effectiveness. Some of the methods was to offer participation incentives, to use a more empathetic approach to the beneficiaries. This was very important. Our field coordinator had in-person communication with them. He tried to raise awareness about the disease, to answer to questions, and build personal relationships, which were very important for them to gain trust and get screened. At another level, we implemented a human rights protection program, which is called Health Without Barriers, and was funded by the EEA grants mechanism. This program was aiming to eliminate stigma and discrimination behaviors inside prison settings through awareness and education. And of course, we try to increase our advocacy initiatives towards the Ministry of Justice and the Ministry of Health in order to issue social security numbers to all prisoners, because this leads us to lose almost half of our beneficiaries without being able to offer them treatment. This new strategy increased our effectiveness from 52% at the screening procedure effectiveness, from 52% to 82%, which is 30% in total. And this was a huge win for us. But the social security number barrier is yet to be considered, and we need to increase our advocacy initiatives because, as I said before, it leads us to lose almost half of the beneficiaries. Besides the challenges and barriers, Access for All was mentioned as a good practice example by the WHO. Was at the Healthcare Business Awards, and some conclusions about the program is that it is a lasting case study and an example of what needs to change at the healthcare system, not only in the prisons environment, but also in general, because the gap between patients and the public healthcare is getting even bigger when it comes to marginalized populations, such as people in prisons. The mapping of barriers and the coordination of stakeholders made us all these years the missing link at the cascade of care, connecting internal prison services with external services, such as hospitals and doctors. We offer precious and long-lasting data regarding hepatitis C in prison settings, which it is worth mentioning that this kind of data is are not available in Greece since 1995. We implement a cost-effective methodology, and our ultimate objective is the program to last as long as possible and contribute to Hep C-free prisons in the whole country. Last but not least, we aim to share best practices and conclusions with European and international stakeholders. Thank you very much for listening to me, and I'm here for your questions.
Thank you so much. I mean, I think the European region really leads the world in quality work for people who are incarcerated, and that was just another fantastic example. So now I'm going to hand over to my co-chair, Marcelo, for the Q&A.
Hi, participants, please use the chat box and the discussion forum to submit your questions. Meanwhile, I have one question for each one of our presenters. The first one, our colleagues from Prometheus, who just presented, regarding the stigma and discrimination. What else can you tell us about the double burden that is faced for those that just been discharged and now facing real life outside of prison? And how does the follow-up for treatment and prevention services have been occurring? How swift has that been? And for our colleagues in Ireland, the question is about the competencies that have been developed for the peer workers and for the nurses This is something that Carrie and I were talking throughout the days. Sometimes we're not really the best communicators and the best in conveying the message. And perhaps we need to work on our knowledges and attitudes and practices. And what have been your perception during the execution of your work?
Thank you for your question. I'm Yannis from Prometheus. The stigma and discrimination is mainly inside the prison settings. We don't have data when someone is released, but since we made a big, we implemented a huge human rights program which was dedicated to this. We found very precious data about these behaviors that lead to everyone who is diagnosed, almost everyone who is diagnosed to get this kind of behaviors of stigma and discriminations. But as far as released people is concerned, we don't have enough data to tell something.
Thank you. Our presenters from Ireland. Nicola?
Hi, this is Marcus here. Can you hear me?
Yes.
Thank you. Apologies, I was having a bit of difficulty with my feed. Nicola will say a little bit about the peer programs that Community Response and the Hepatitis C partnership have running in general. I will talk a little bit about the issue of peers and nurses and that kind of network in the drive to eliminate. So one of the key things that we saw when we went out and we spoke to people was that there were these really good examples of peer work around the place. So in Ireland, we have, for example, linked to one of our major hospitals in Dublin, peer workers that are embedded into clinical teams. They can go into the community, they can do testing in community agencies, they can do initial screening. We have nurses then who can do follow-up phlebotomy again in the community. And then those people, if people receive a positive screening in the community, they can be referred very easily to the hospital setting. And we have good examples of people, being detected in the community and then being referred into the hospital setting and starting treatment a matter of a couple of weeks later, so 3 or 4 weeks later. So we have these extremely good models that are in use, and the challenge that we face, or one of the key challenges that we face, is that that accessibility isn't everywhere. So where I live in Dublin, I live within 20 minutes of 5 of the hepatology, 5 of the 8 hepatology units in the whole country, and that's just not the same when you're outside. When you're outside the city, distance is a real factor, and in order to engage with people and to support people to access services where simply getting to hospital can be a big barrier, we need to have a peer and nurse-led network that can do that. And one of the recommendations we make is that it would operate on a hub and spoke type system where you have peers and nurses on the ground in the community, in places like clinics, in GP services, and linked into back to hospitals for care as needed, but that the majority of care would be on the ground where people are provided by peers and nurses. Nicola, do you want to add to that?
Yeah, thanks very much, Marcus. And thanks to everyone on the call today and to the organisers for allowing us the opportunity to speak. Yeah, I think just to say two really clear points for us that has come out of the learning and our experiences of peer training. And interestingly enough, like our colleagues in Greece with Prometheus, we've done peer training programs in the prisons in conjunction with the Irish Red Cross. So we had a really good experience with learning what that was like. Obviously, time is very limited here. So I would say for ourselves at this point now, we've trained in excess of 40 peers who've been utilised predominantly to my shame in Dublin, but also in other parts of the country to a more limited degree. What the peers have allowed is to address some issues around development of relationships, which has led to that bridge of maintaining care, easing access, and also moving on for maintenance around aftercare. Many of the people impacted by Hep C in Ireland are from the IVDU current or former population and may not have always had positive experiences with the healthcare system. And to work with someone or have support of different levels from a peer perspective, it addresses some of those concerns. It allows for a relationship to develop, which also addresses some of the significant issues around stigma within treatment as well. So I would say all the benefits come from, there's benefits for peers themselves, but there's huge benefits in terms of the quality of the relationship that assists for maintaining care. Thank you.
Thank you very much. I'd like to remind all participants that these abstracts and many other abstracts are available in the platform. For those who like to share beyond the World Hepatitis Summit, I'd like to remind that we have the WHO Virtual Library. We may be of assistance for submission of chapters as a follow-up to several compendia that have been released by the regional office for the European region. So please, let's continue to contribute with the scientific developments and community empowerment for viral hepatitis response. Due to the advance of time, we're going to follow up with the next session. So I'm just going to give the word to our next moderators.
Thank you. Can you hear me? Hi, Carrie. Can you hear me?
We can hear you. We can hear you, Rachel. Go on.
Okay, sorry, I have really bad reception, so forgive me, everybody, please. But I'm delighted to be here for the second section. Sorry.
No, I think you can carry on.
Antons, are you there?
Yes, Rachel, we can hear you. Would you like to go on, or would you need to take over?
Hi, can you hear me now? I'm really sorry, my reception is really bad. Perhaps if someone could let me know if they could hear me, and then we could move on to this really
Rachel,
important session, which is about good practice and key actions towards elimination. Oh, thank you. I know you can hear me now. I'm delighted to be here with my colleague from WHO, Anton Mozalewski. Sorry, forgive me if I'm saying it wrong. I'm not going to do many introductions aside to say, but we have three really great presentations on good practice. We are doing, I know there's a lot to do across Europe, but we are doing some amazing stuff as well. So first of all, I just want to go straight into our first presentation, which is a strategic plan for tackling hepatitis C in the Spanish national health system. Spain's doing incredibly well. And we've got Dr. Julia del Amo from the Ministry of Health, Spain. Julia, over to you.
Thank you very much. I believe you're hearing me, which is great then. So good morning, everybody, and thank you very much for inviting the Ministry of Health to be part of this summit. I'll address the strategic plan for tackling hepatitis C in the Spanish national health system following this outline. I'll briefly show you how the strategic plan
We cannot hear you, Julia. You're muted.
Yes. Hello, can you hear me now?
Yes, but you have an echo.
I know, but I cannot do anything, I'm
That's
afraid.
okay. Let's do with the echo.
Sorry. I was
Sorry to interrupt. Are you listening to the streaming on the platform?
No, I'm not. I haven't done anything different to what I did this morning.
Okay. Are you listening to the streaming with, well, to the Zoom with a net phone?
With a
headphone?
No.
Okay. So I think you should then decrease the sound of your laptop to avoid this echo.
Okay, is this better?
It seems, yes.
Okay, I'll continue if that's all right. I hope it's not too annoying.
It's perfect now, Julia.
Great, thank you very much. So as I was saying, the strategic plan to address hepatitis C in the national health system in Spain was published in 2015 with the objective to reduce morbidity and mortality by hepatitis C in the Spanish population, addressing prevention, diagnosis, and treatment. And there were obviously lots of different initiatives in these three pillars. I will briefly show the uptake of direct acting antivirals over time and its impact. And as you can see in this slide, from April 2015 till December 2021, over 154,000 patients were successfully treated with DAAs. You know, the clinical effectiveness of this treatment also in real time is over 98%, and this is the situation in Spain. As time went by and the number of patients who were candidates for treatment decreased, the number of new initiations decreased as well. But worryingly, the beginning of the COVID-19 pandemic gave rise to a sharp decline in the number of new hepatitis C DAA initiators, which picked up slightly, but not sufficiently. And we are aware that COVID has negatively impacted testing and treatment uptake, and we're trying our best to reverse this. As you can see in this slide, the number of people who initiated treatment with DAAs with advanced hepatitis C disease has improved over time. People with a 4 accounted for 41% of treatments with DAAs in 2016 and only 24% in 2021. Opposite, people in 2021 who initiated treatment with DAAs in F0, F1 were close to a half of the people being treated. As a consequence of this, the numbers of transplants related to HCV infection in Spain have declined abruptly from 2016 onwards, as you can see in this slide. So has the waiting list for transplant related to HCV. So what about the epidemiology of HCV in Spain? We look at data in the general population and high-risk settings. The data from the general population comes from this large national population-based survey conducted in 2018 and which was published in the European Journal of Public Health over a year ago. In summary, there were over 7,600 participants randomly selected across primary health care. So this was a representative sample of people registered in their GPs all over Spain. The prevalence for HCV antibodies was 0.85%, and the prevalence of active infection was 0.22%, with this relatively wide confidence interval. The prevalence in people aged 20 to 80 years of age have just shown you 0.85% for antibodies and 0.22% for active infection, of which the undiagnosed fraction was 29%. The undiagnosed fraction for antibodies, as expected, was lower. There was a sex and age difference in the prevalence of active infection, as you can see in the slide. Prevalence of active infection was higher in men in blue color than in women in red, and particularly men aged 50 to 59 had the highest prevalence of active hepatitis C infection, amounting for 0.86%. In population terms, this meant that of the over close to 35 million inhabitants in Spain in this age range, and given a prevalence of HCV active infection of 0.22%, we would have just under 77,000 people with active HCV infection in Spain. But given an undiagnosed fraction of 29% for active infection, this meant that just under 22,500 persons had undiagnosed HCV infection, and the opposite, over 54,000 had diagnosed infection, of which we had evidence in the survey that half were already on treatment with DAAs, 17% had no evidence of linkage to care. This was over 9,000 people, and 33% had no information. But we may assume that the distribution of these close to 18,000 people would follow a similar pattern, and that over half of them would be under treatment already. So what about the situation in high-risk settings, such as the prisons? These are the prison settings in Spain, except for Catalonia and Basque Country, which have their own registries, but the success story is similar in Catalonia and in the Basque Country as well. As you can see in this slide, there's been a marked decline in the prevalence of antibodies to hepatitis C in green over time, but more excitingly, a reduction in the prevalence of active hepatitis C infection, PCR, in red from 11% in 2016 to just under 2% in 2019. And similarly, in people with HIV infection, marked declines in the prevalence of active infection in orange from over 50% in the early 2000s to under 4% in 2018. So based on this information in the general population and in high-risk setting, we developed the guidance for HCV screening in 2020. It should have been done earlier, but it wasn't done. So by 2020, we developed this guidance, which of course had to respond to the rapidly changing epidemiology of HCV over these years. So the guidance that we would have written in 2015 would have been very different to the one which was needed in 2020, that needed to focus on groups with high prevalence. This technical group was integrated by lots of people. For the sake of time, I will not go into detail, but just to thank everybody, because this was a really collaborative and very interdisciplinary effort. The guide identifies to test people with risk exposures for HCV infection and high-risk settings, which includes entry into prisons and people that originate from countries with medium or high prevalence of HCV infection. Not any migrant person is offered testing unless they come from a medium or high prevalence setting, or they fall in the group of people with high risk exposures. You can see in the slides are the ones that have been identified in the past, and I will not go into detail, but obviously people with HIV infections, the one we've just seen before, would offer frequent and targeted testing. Now, we are in the process of following up the implementation of this guidance on HCV screening in Spain. We've had 2 meetings in 2021 and 2022 to make sure that the different regions in Spain is a highly decentralized country with 17 regions in 2 autonomous cities that have autonomy to implement this action. So in these meetings, we've already identified this margin for improvement in the implementation and the coverage of screening populations and in high-risk situations, that there is also heterogeneity in the implementation of the active search for patients who had been already tested, both for antibodies and for PCR, but that there is no evidence that they have linked to care and started on DAAs, that there is also challenges to coordinate with drug addiction centers, prisons and communities, STI centers. We obviously need to address new infections and hepatitis C reinfections in the context of chemsex. And of course, we need to continue promoting screening based on risk risk situations in the general population and at-risk population, and of course, training activities that, as we've already seen, were heavily disrupted by the pandemic. Just to remind you our firm commitment towards SDGs, we have made strong advances, but there are key challenges and we are very committed. Thank you very much, and I'll be happy to take questions. And then, sorry for the problems with the hearing. Thank you very much.
Thank you very much, Julia, for the presentation, as always. Okay, Rachel, do you have anything to comment or no?
Just very quickly, I just wanted to say incredible work and how important the review of policy, of government policies, kind of looking back, reviewing and updating them. And I was really, really pleased to hear you mention reinfections, because I think it's something we all need to be aware of as we move forward, rather than being focused on first time, but we do need to have things in place to deal with reinfections. But I'll hand back to you, Antoine, for the next speaker.
Thank you, Rachel. Yeah, maybe just also a quick feedback on the presentation from Julia. I think this is also an excellent example of how the data can be used for guiding the focused and targeted so really great to see already the impact of treatment of hepatitis C on morbidity and mortality. You mentioned the reduction in number of transplants, but I know there are also some article published on the impact on hospitalizations due to liver disease, and also I think also on mortality. So I think it's really motivating also for other countries. So we really can see that these efforts on a national level, they can also have a real impact in a relatively short time, I would say. So maybe if we will have more questions, we will of course have them in the end, but I would like to invite our next speaker, who is Professor Erkin Musabayev, who is the Director of Research Institute of Virology of the Ministry of Health of Republic of Uzbekistan. And he will present the Uzbekistan Hepatitis Elimination Project, and also really glad to see Professor Musabayev, and also that we can have a presentation from a country where hepatitis B and hepatitis C are quite high burden in the general population. So comparing to Western Europe,
just a moment, Anton, I have some technical problem. Just a moment.
I don't know if the colleagues from the technical team can share the presentation or.
Okay.
Excellent. Thank you.
Excellent.
So.
First of all, thank you very much for invitation to this session. It's very glad to introduce our work, which we begin 4 years ago. When we receive not enough money, it is available little money for our country, $1 million from budget from our governments, and at this time and now too we have 600,000 estimated patient with hepatitis C and near 1 million patient with hepatitis B, and near 20% of all hepatitis B, it's hepatitis B plus D. Situation is very danger in our country, but we try to explain it to government, and first step was budget for a little part, maybe 10% of all patients with hepatitis B for treatment these patients, and extra money for restructuring our health system care, and organized special center at every region. We have 12 regions in our country, special hepatological center, where is a center responsible for the diagnostic and treatment of viral hepatitis and all complications of viral hepatitis. Next step was when we received.
Are you trying to move the slides, because we can see on the first slide? Maybe you can.
I don't understand.
Move to the next slide.
No, this slide.
Okay, so you.
This slide. Then we receive a project with SDA Foundation, and the aim of this project was treat 250 test 250 population and Tashkent city, but pandemic changed our plan, and we treat only 62 not treat test at 62,000 population. I want to explain shortly about this pilot project. Main goal of this pilot process is to demonstrate effectiveness of simplified recommendation on screening and treatment of chronic viral hepatitis. Other in country could implement this project at the national level and achieve WHO goal on elimination of viral hepatitis by 2030. We organize special work when we give free of charge test system for all population which participate in the pilot project. Then we organize treatment for 20% of patients free of charge, and decreased to 2 or 3 times price for patients who are not included this free of charge group. It's both.
Dr. Musabayev,
yes.
Just I excuse me for interrupting. I think we cannot see the further slides. Maybe you can move to the because we can see only the first slide on the screen yet.
Yes.
I don't know.
Can you see? You see?
No, we see only the first slide.
Only?
Can you move down the?
Yes,
slide?
yes. You see or not?
No,
No,
we see
Dr.
only the
Musabayev,
first.
can you exit the presentation mode and use the third button that you see next to the Zoom bar on the PowerPoint window, please?
I don't know.
I'll guide you with the mouse. Press Ask. Move your mouse around, Dr. Musabayev.
Yes, it's good.
Okay, go to the bottom bar of PowerPoint window.
Bottom PowerPoint window. Good.
Have you pressed the Ask button, Dr. Musabayev? Have you exit the presentation mode?
Sorry, I don't understand what I must do.
Press the top left button in your keyboard, please.
I press yes, left, yes.
Top left keyboard button that you have on your computer. Should be the Ask button. You will exit the presentation mode.
Just a moment.
Oh,
yes.
Yes.
Perfect.
Yes. Yeah. Yes. Next slide. Okay. Good. Anton, do you see?
Yes. Now everything is perfect.
Okay. We increase price for this treatment for 8% of patients, and free of charge for 20% of patients, both for hepatitis B and hepatitis C. And they demonstrate that it's possible to organize outpatients polyclinics, screening for many population of these polyclinics. And it's approximately time for screening patients, and of course, when we organize treatment HCV and HBV positive patients, we receive that only half of these patients go to the consultation, and only half of these patients who receive consultation pay for the treatment. Its situation was both, and for hepatitis C and for hepatitis B. For hepatitis B, situation was better, but 65% indicate treatment if we estimate all patients who receive consultation. Very important part of our work was organize special register, data collection, and patient register for this work. We include all 62,000 patients to this register, and now we disseminate and this work at our regions. All patients' consent, contact information, medical history, test register, and doctor's note, and entered into REDCap electronic medical register that was developed to monitor patient progress through the program. All polyclinic and research institute medical staff were provided with low-cost digital tablets and laptops, including cellular wireless routers will need to allow the recording and near real-time loading of patient data. The register system prevents repeat testing and provides a mechanism for follow-up with patients are not linked to care. You can see that we stop our work during for approximately 4 months because it was pandemic and Institute Virology was closed and for treatment and diagnostic coronavirus infection, but we continue our work. It was real good experience, decentralization of this work, because most patients who was diagnosed go to the treatment inpatient, outpatient hospitals, more than patient who was at the Institute of Virology. It's key project statistics. We are screening about 1,800 people per week, and during this time we diagnostic 1,700 HBs positive and 1,600 HCV antibody positive cases. That it was good practice, and it was the basis for include to this project 6 regions. It was continue SDA project because it we receive budget money for free of charge testing and PCR diagnostic at the 7 region. Now in 2021, we plan to test, to screen 500,000 people. Now we screen 200,000 people, and we use previous using database RedCap system for include all positive patients to the special register of hepatitis B and hepatitis C. It was the basis for explain government to improve measure and to combat the spread of some topical viral infections, and we received special president decree 3 weeks ago, and little part of this financial part of this decree, we plan to screen every year approximately 1 million population for hepatitis B and hepatitis for hepatitis C and hepatitis B, because hepatitis B is big problem for us too, and we include in this program not only hepatitis C but hepatitis C. It was active screening, approximately 500,000 population, and passive screening because all patients before delivery, before treating some surgery operation, to make test for hepatitis B and C. We organize collection, we collect this data, and we plan to include this date to the national register. Then we plan to receive near $1 million for treatment hepatitis C, and we estimate if we one cost of this treatment will be $50, we can treat near 20,000 patients. It's we estimate that if we will treat near 40,000 patients every year, we achieve to the goal of WHO during 10 years. And then I think it's very important part of this project. It's screening all positive patients to the onco markers, PIVKA and AFP3, because really disease body of hepatocarcinoma at our country very high. We estimate that if official at the cancer register we have 6 patients per 100,000 population, but really we have 50 patients per 100,000 population. And the early diagnostic of early stage of hepatocarcinoma, it's very important aim of this program. It was hard time. We work at the pandemic time. You can see that we work sometime in open air because it was danger work in the inside of the polyclinic. And thank you very much for all participants of this program. And I think this our future work will be successful. Thank you for attention. It's all organization who was participate at this work. Thank you very much.
Thank you very much, Professor Musabayev, again for an excellent presentation and also showing the results of the pilot and also how it leads to the extension of the program. I think it's also a very good example of data that can be used for further action. So there are already some questions, but I think I will leave it to the end. So we have still 25 minutes for this session. And I would like to invite our third speaker, and this is Dr. Ketevan Stvilia from the Georgia National Center for Disease Control and Public Health. So she's the head of the Global Fund HIV program manager, but also very closely involved in hepatitis C elimination program, which now will be extended also to hepatitis B. So I think it's also very good development. So Katie, can you share your slides? And the floor is yours. Welcome.
Do you see my slides? Hello, everybody.
Yes, we see them, but again, not in the presentation mode. I think maybe Marcela can.
Is it now in presentation mode?
Yes, perfect now. Thank you.
Thank you. Thank you for the opportunity to present Georgian case for hepatitis prevention, testing, and linkage to care of people who inject drugs and our achievements and our future goals. And I would like to start first with the overall overview of our MC elimination program. In 2015, we conducted national cell survey and identified that 5.4% of adult population was living with hepatitis, active hepatitis C infection. This survey informed our national strategy for elimination that has very ambitious goal to eliminate disease by end of 2020. Of course, this required a very aggressive pace of implementation, first of all for screening program. During 5 years of first phase of elimination, we conducted almost 5 million screening. And we screened 2.1 million adult population, which is 75% of overall number of adults in the country. Some population groups were assigned to mandatory screening, but people who inject drugs are not included, of course, in this group. but they were prioritized and they were provided with access to screenings through needles and syringe program and opioid agonist treatment program. This is the current achievements and for the overall national cascade. And we were able to identify almost 96,000 individuals with active infection. From them, almost 77,000 initiated treatment, 76,000 completed treatment. And among those who had a SVR test, we also, like our Spanish colleagues, we have also very good cure rate, 98.9%. For people who inject drugs, we conducted population size estimation, and we estimated that number of people who inject drugs in Georgia is 52,500. Percentage of hepatitis C antibody positive people who inject drugs, according to different studies, was different but quite high, more than 60%. According to the same studies, prevalence of hepatitis B surface antigen was between 3 and 5%. As I mentioned, people who inject drugs have access to hepatitis C screening through needle and syringe and substitution treatment programs. Needle and syringe program provides screening, and also as a part of extended comprehensive package, we provide linkage to care through case management. We conduct patient schools to support adherence to treatment. And also 5 needle and syringe sites have developed on-site RNA testing capacity, and they are using gene experts for testing. On the slide, you can see geographic distribution of needle and syringe program sites. We have 16 sites, plus we have 9 mobile ambulatories that expand service coverage to more than 45 cities of Georgia. And we have 100 peer workers that also provide services. And they all are trained on provision and counseling on hepatitis as well. During the ESF implementation of hepatitis C elimination program, number of people who inject drugs who were reached with the needle and syringe program services increased dramatically, including last year. We were able to provide services to more than 35,000 individuals. And as for hepatitis C antibody screening, almost 28,000 people who inject drugs were screened only last year, which is about 58% of estimated number of this population. And for hepatitis B surface antigen, almost 31,000 people who inject drugs were screened. As I mentioned, on-site RNA testing capacity is developed at 5 needle and syringe program sites through Find Head Start demonstration project. And from June 2018 through end of 2021, 3,772 RNA tests were performed at needle and syringe program integrated sites, including about 3,000 tests that were performed for controlled for reinfection with positivity rate of 7.4%. During the same time period, with the US CDC support, needle and syringe program sites were able to integrate hepatitis C treatment as well. So we have 4 integrated treatment sites at needle and syringe program and 1 clinic at opioid substitution treatment program. This is private clinic that provides Suboxone. People who inject drugs in needle and syringe program are registered by unique identifier, not personal ID. That created some problems in assessing the enrollment in hepatitis C care or completion of treatment. But from 2018, we started requesting personal ID from those who would test positive on antibodies, and we were able to construct this cascade. This does not provide full picture of people who inject drugs who were really treated during elimination program, but it provides some understanding what is happening with this population. So dark bars represent overall numbers, and light blue bars represent numbers from integrated sites. So we see that integrated sites did very well in terms of providing RNA testing. 84% of individuals who were registered at a needle and syringe program site received RNA testing at integrated sites. But for the rest of the cascade, the percentage is between 20 and 24%. Overall cure rate among those who received the SVR test, which is 71% those who completed treatment, was quite high, 98%. We have quite good coverage with the opioid agonist treatment program in Georgia. We have 22 sites. Geographic coverage is 12 cities. Overall capacity of program is between 14 and 15,000. During COVID-19 epidemic, patients were able to receive 5 days take-home dose. In prisons, we don't have substitution treatment, but we have a longer-term detox program with the capacity to provide services to 500 patients. Since 2017, all services are now funded from the state budget. But the issue that we observed among opioid agonist treatment patients, as we did not have integrated sites in this program, we could not track them for Hep C treatment and care because they were mostly utilizing general healthcare system as the rest of the population. And this process was well supported with the centralization of hepatitis C diagnostic and treatment. On this slide, you can see the current number of sites that provide hepatitis C diagnostic and treatment. And initial number in 2015 was 4. And as of today, we have 39 sites. The centralization was supported by the primary healthcare service. In order to understand what is happening with the substitution treatment patients, we conducted special study with cross-match Hep C elimination database with the opioid agonist treatment program database using personal ID numbers. And we constructed cascade for opioid substitution treatment patients that were receiving treatment during 2018 and 2019, and results were really surprisingly good. We observed that 71% of all opioid substitution treatment patients were registered in LMC database. 86% of them were tested for RNA. 90% of them 88% confirmed with a chronic infection, 85% were enrolled in treatment, and 94% those who were enrolled in treatment during this period completed treatment. The issue was with uptake of SVR test, but when we compared the results of opioid agonist treatment patients with the overall national cascade for the same period, we found that results were pretty comparable. For some steps of the cascade, results were even better. For example, for coverage with RNA testing or for completing treatment, and for SVR, results were comparable, 97% for opioid agonist treatment and almost 99% for general care cascade. All these interventions has resulted in dramatic decrease of active infection among people who inject drugs in Georgia, which was confirmed by sero survey that we repeated in 2021. And according to last study, active infection prevalence among people who inject drugs has dropped from 51.1% in 2015 to 70.8% in 2021. These findings were also confirmed with the BSS Light study. This is new methodology developed by UNAIDS and WHO, simplified behavior and biomarker surveillance survey. We implemented this this year, and the biomarker screening data of 2,000 people who inject drugs in 7 cities showed that the rate of active infection in this group was 14.7%, and the RNA prevalence for hepatitis B was 3%. Of course, we understand that we need to continue our work to sustain the results and further decrease rate of active infection among people who inject drugs and prevent spread of hepatitis in this high-risk group. We plan to expand number of integrated sites. We would like to reduce loss to follow-up, improve linkage to integrated sites for treatment, reduce time from positive RNA test to initiation of treatment to less than 2 weeks. We plan to do qualitative studies to understand barriers that prevent people who inject drugs from seeking diagnostics or treatment. And we would like to establish the surveillance on this group, and we will provide not only antibody testing among people who inject drugs, but we will establish RNA and co-RTGR testing at least at some harm reduction sites that we plan to use as a sentinel sites. We updated our national elimination strategy. Now we are in the phase 2 that will end in 2025, and we hope very much that by that time we really will report elimination of this disease in Georgia. Our work would not be possible without great support of our international partners, WHO, CDC, FIND, the Global Fund, and our local partners, Ministry of Health, Georgian Harm Reduction Network, and Center for Mental Health and Addiction Prevention. Thank you very much for your attention. I'm happy to take your questions. Thank you.
Thank you very much, Katie, for also excellent presentation. Like we had all three of the presentation in this part of the session really exciting and interesting. We have a bit less than 10 minutes for questions and answers. We have one question from the audience. I understand this is for Professor Musabayev for Uzbekistan. The question is, what was the biggest challenge for developing the patient registry, and what are the lessons learned from overcoming those challenges? Thank you.
Thank you very much for questions. Big challenge, big challenge. It's knowledge of this gnosis, because it was difficult to explain and organize as the pilot project, organize education of this low knowledge of gnosis who use this computer for making national register. I think it will be a biggest problem for us when we involve this pilot project, and we will work at the national program.
Yeah, thank you very much. So I think, yeah, I know I've heard that there were a lot of trainings for nurses. So I think this is
Yes,
also
of
the
course.
lesson learned.
It is needed. It's necessary. You know, many sites will be involved to this work, and it's a big part of this work. It's training of the nurses.
But I think it's also a gain for the overall healthcare systems because it increases the literacy, the use of IT, and I think that it will benefit the overall program. So thank you. I think I would like to ask a question to Julia, if you're still with us. Yeah, I see. Sure. Regarding the testing patients in other health programs, in other settings, not in primary, but also maybe in TB clinics, in STI clinics, and so on. So, what is the collaboration with other programs and testing for hepatitis C and B?
Thank you, Anton. Can you hear me without the echo, right?
It's okay. Yeah.
Great.
A little bit echo, but we can. Yeah.
There is collaboration in paper and in practice most of the time. So of course, it's not perfect. There are challenges. As I didn't have time to mention that a few months ago, late 2021, the Ministry of Health created a new division that integrated the response to HIV, to STIs, to viral hepatitis, and to tuberculosis. We were de facto working as an integrated body, but now there is a division that is called that way. So this makes collaboration a lot easier because it's part of our mandate. So structures are important to facilitate this interaction. So there are challenges. We wished implementation of the guidance was 100%, but we're there. Thank you for the question.
Thank you very much. Maybe anybody from the panel or from the chair in the room in Geneva, maybe you have any questions to our speakers in the session.
Okay, Julia Dellan, this is Luís Mendão from Portugal. Just a curiosity, how is the HCV infection controlled among MSM HIV positive and non-HIV positive? Because I didn't see any data.
Can you repeat your question, Luis, please?
So if you have any data about the transmission rate, the incidence among of HCV, hepatitis C, in HIV positive MSM and in HIV negative MSM.
Thank you, Luis. There are a lot more data than hello, Luis. It's lovely to see you, first of all. There are more data regarding HCV incidence and HCV reinfection in MSM who are HIV positive too, because many of them are in cohort studies. There are less data in HIV negative MSM. We are equally worried about reinfection rates in these groups, but collecting those data is a lot more challenging. But yes, there are data, and although numbers of reinfection rates are not huge, they're not negligible. And I think because of the small numbers, it's very important that European collaborations look at this issue together to have reliable estimates of these reinfection rates.
It's Rui from Portugal. Hello, Julia. Nice to meet you. How many days does it take to get the drug after the prescription of the doctor?
Sorry, I hear the echo. Can you repeat the question, please?
How many days does it take to get the drug for the patient after the prescription of the doctor?
That's a very good question, because in Spain, all antivirals, well, not all, but DAAs and antiretrovirals for HIV as well are only prescribed in hospital pharmacies by law. This means that if you need to prescribe DAAs to someone who is not in the hospital setting, you need a special arrangement with a hospital pharmacy, which is not always straightforward. And this is problematic if we want to have treatment on site in, let's say, mobile units of people who do not frequently go to hospitals and do not wish to go to hospitals. So that is challenging because primary healthcare in Spain is not entitled to prescribe DAAs. There are specific arrangements, and there are some good practices. Some community centers like Checkpoint in Barcelona have arrangements with hospital pharmacies that work well, and we're trying to mimic that good practice. Thank you.
But in hospital is in the same day of the prescription?
In hospital.
Is in the same day?
I don't know if it is in the same day. I don't know. I believe there'll be lots of heterogeneity here, but I can check the clinical network. It is quick, though. I'm told it is fast. I wouldn't know if it is the same day. Thank you.
Hi, so I have a question for Georgia. Hi, I just wanted to ask you, a great presentation as it was from everybody, but I wanted to ask you about and point and mention the decentralization, fantastic, but it appears in the presentation that the focus is very much on people who are accessing drug services. Is there an issue? What kind of resource or attention is there for people who are using drugs but do not access drug services? Because I know that, in the UK, there are groups of people that are accessing drug services, but a lot that don't. So do you have some kind of provision that you're working towards to include them?
This is a very good question because of the criminalization of drug use and stigma. You are absolutely right. Not all people who inject drugs access drug services. And that showed, like I presented, opioid substitution treatment data. So even people who do not go to harm reduction services, apparently they are well informed of hepatitis C elimination program, and they go through general health care, but as I said, they do not report their risk behavior. And therefore we are losing real picture for people who inject drugs for hepatitis C care, but as a general population, they have very good access to care. Besides, almost every year we implement so-called PDI intervention. We incentivize our users to bring new clients to the program. That is always very successful. And this way we are trying to reach those who are not current users of harm reduction services.
Incentivization is interesting. I think it works. And lots of different countries have lots of different opinions on whether it's a good thing or not. I personally think it's a good thing to incentivize people, to encourage
especially
them.
During our current phase of elimination, when we already treated lots of patients, it's always very hard to find new patient and get enrolled in.
Yeah. Thank you. And just quickly also, with the work in the prisons, are people tested? Is everyone tested when they go into prison? Is it a regular testing program or is it one-off?
Yes. This is entry lab investigation for everybody, and those who are positive, actually we have very good prison program for hepatitis C treatment. We are really proud of that program.
Fantastic. So Antonis, before I don't have any more questions, but I just have one comment I wanted to make across to everybody. Fantastic presentations, thank you. And the similarities that really stood out for me was that each of your countries has policy in place, and that your surveillance and your data collection is amazing, which is, you know, what it shows is with all these things in place, you can move forward, and you, and I appreciate in that because forgot, sorry, on which one is it here? On there's, it's because I can't pronounce it. Uzbekistan? Yeah, enormous prevalence, but the incredible work in terms of surveillance, which is where we, you know, unless we know what we've got, we can't work, we've got nothing to work with. You know, it's all together to get the declaration at the same time. So I think it was the commonality between having the strategy in place, the government commitment, and the surveillance and the data collection alongside, you know, access to treatment, etc., really shows that, you know, in examples of best practice, this is what's needed.
Thank you, Rachel. And I think also I don't see any questions coming in. We are a bit already over the time. So if there are no more questions, maybe I would like to summarize and to say some final words to Dr. Nicole Segui. Nicole?
Thanks, Anton. Yeah, just to summarize what we learned from our presenters today. First, the importance of having a well-thought, large-scale testing strategy and the decentralization of services up to the primary healthcare or GP to increase access. We also learned the importance of community engagement, first to advocate for a funded program, but also to support testing and treatment follow-up and make sure that no one is left behind, including people who use drugs and people in prisons. We also discussed the importance of reviewing where we are, assessing barriers along the cascade of care to understand the bottlenecks, and look more granular geographically and in terms of population groups access. So that's what we mentioned lately, the evidence-based approach that requires good data, both from surveillance and from the program, that is essential to make progress. Finally, the experience sharing across countries of the region is a plus. We can see that sub-regions are getting together because they have similar health systems. And it's very important to allow this sharing of practices. So that's what we are doing today. That's what we are doing also through submitting good practices in the WHO virtual library. And also, I'd like to thank Georgia, that has a quite mature program now to help Central Asian country, in particular Kyrgyzstan at the moment, that is developing their strategy. And also I was in Kazakhstan lately and in Uzbekistan. I could see a very nice meeting where Professor Musabayev was there together with his colleague in Kazakhstan. So exchanging between Kazakhstan and Uzbekistan was very, very useful. So WHO and our collaborating center stands ready to support the countries in their pathway to elimination. We have other partners very engaged in making sure that we are going the right way. I would like to thank our member states for their commitment to eliminate hepatitis by 2030. We hope that the new incoming regional plan will provide an opportunity to refocus. Just to let you know, we are planning a ministerial briefing during the regional committee meeting in September to increase political commitment to elimination. So thanks again to all our presenters, Professor Musabayev, Julia, Kitty, Yanis, Nicola and Marcus. And thanks to our chair, to our colleagues from the World Hepatitis Alliance. And thanks to all participants for in this regional session. Thank you very much and have a good lunch and afternoon.
Thank you very much.
Bye.
The doctor told me that, look, you have hepatitis B, so you cannot go overseas. no one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check. And hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time, I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado. Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado. Soy Rubén y estoy curado.